A great pleasure to be here among friends and colleagues. More importantly, it's so happy to see people back again in person. Last but not least, I'm very pleased to see that this meeting is growing successfully. I'd like to make this as entertaining as much as possible. Sometimes CTO technical stuff could be boring, but I was given the task to share with you wires with the title of Broaden Your CTO Guidewire Algorithm. I think if you look into how brain works, we work in algorithms all the time, and we've adopted algorithms in CTO in many different scenarios. And this case that we just did about a couple of weeks ago would illustrate that. I just want to share with you the new cardiac center that we have moved in very recently. We thank the United Arab Emirates to fund and support this center in Bahrain. Thank you very much for your generosity.
Good morning or good afternoon to my colleagues and friends at the Gulf Intervention Society meeting.
So I don't think you can hear it well, but this is the case that's been joined by my colleague Noor and Dr. Sadananda, who is here within the panel, and the rest of the team at our MKCC.
And the great
I forgot her name.
Denise, and the rest of my team. So we have a very interesting CTO of the proximal LED. We'll share with.
Let's dive in. So this case is a 56-year-old male with history of smoking. He presented initially with non-STEMI. He has normal GFR and hemoglobin, and he has stable hemodynamics. So I'll share with you, I can't see my mouse, sorry. So this is the angiogram. I think when we talk about CTOs, one thing we always, we'll come to that. So this is the initial angiogram that we did. And you can see there's a significant RCA lesion. This was the presenting culprit, heavily calcified lesion. And the lymph system has some mild disease in the ramus. And as you can see, the LAD is occluded, as there are some collaterals from the ramus system to the left anterior descending system as well. You guys could stop me at any point. We have time, about 15 minutes to finish this presentation. So if you see here on this is initial diagnostic angiogram, the LED is flash occlusion from the left main. So we proceeded, my colleagues actually proceeded with the image-guided PCI of RCA. The guide was using Amplas because we thought at that time we needed some support due to the calcium. This was intervention as usual. So he was brought back to perform the CTO of the LAD. There are a few challenges in which we will discuss. And we've gone radiofemoral, and we minimize the femoral approach as much as possible, but in this case we went radiofemoral, 7-French system in each axis. And as my previous colleague said, we always keep a safety wire. We actually kept a safety wire in the right and a safety wire in the ramus. So that's wire number one here. We're talking about wire algorithms, so workhorse wire of the scion in both limbs. So I think I want you to pay attention when we talk about CTO analysis. So when you have a CTO, there's an area of disconnect between two parts of the vessel, logically speaking. So there's an entry where there's the proximal cap, distal cap, and the area of the occlusion, and we need to connect them. So in this example, in this case actually, the proximal cap is ambiguous. Ambiguous, when we say ambiguous, that I'm not confident enough when I use a very stiff wire to puncture. So that's my definition of ambiguity of the proximal cap. The challenge in this case, the proximal cap is ambiguous. The distal cap is at the bifurcation or trifurcation. I'm not clear on that. We have calcium, and it's a retroflex diagonal as well coming off here, so there's a lot of challenges in this case. Here the patient was shivering, by the way. There's nothing wrong with the images. So multiple views, no panning. It's very, very important not to pan, and you sit down and really analyze the anatomy. And spend time, try to analyze in very much details, because that's going to help you in planning your procedure. So, as in the previous session, we talk about the JCTOs, and the reason we talk about the scoring system, and this is one of the easiest user-friendly system used by the Japanese more than 10 years ago. And it's important to know that your JCTO score, because that dictates the complexity of your cases. Also, that dictates whether you should do the case or not. Also would dictate whether you should refer to a center who can do complex interventions. So the first component of the JCTO score is the cap. The proximal cap. Is the proximal cap ambiguous or not? And we know the LAD would come up somewhere in here. Whether it is here, 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 we're not clear. So that's why we call this cap proximal. The second thing we look into is how long is this occlusion? The longer the occlusion, the less likely you will be able to recanalize in antegrade fashion. So in an estimated fashion, we estimated that the occlusion is longer than 20.
So do you have a pointer to just show us what you mean?
Pardon me?
Do you have a pointer or
Yeah,
not?
it's right there. I have an arrow in here on the other screen. You can see it. I'm going number one by one. So proximal cap, lesion length, which is number 2. Number 3, these arrows pointing out to the calcium. We also have calcification. As we all know, in coronary intervention and non-coronary intervention, calcium is our enemy. And last but not least, is this vessel tortuous? In our experience, most of the time, this segment of the LAD is tortuous, and you will see that later on as the case progresses. So we ended up with a JCTO score of 4, and by all means, anything above 2 is a complex CTO intervention. Then we also came back and analyzed, looking into the details about these collaterals. When you look at the diagnostic angiogram, when you look at the collaterals, they look fantastic. These are collaterals that I may use. But kindly pay attention to these details. These are collaterals from the right going to the LAD system, and these are collaterals that are usable. That means you can use and go retrogradely with a good amount of success. However, don't get persuaded and fooled sometimes that you will see these tortuosity in one view, and when you look in the other view, they're actually extremely tortuous. So pay attention to these collaterals. So we thought we will go, because of the ambiguous cap, lesion length more than 20, calcified tortuosity, and distal cap multiple branches. We thought, and we had good interventional collaterals. We thought, well, it's best to go retrograde so that we would not damage these distal cap, and to solve the proximal ambiguity of the proximal cap. So AL 0.75 guide on the right. We use a guide extension for increased support to the right. We have safety wire and the circ. And we went down with a microcatheter. In this case, we used a Corsair Pro XS for retrograde. and we access the lesion. When we classify wires in general, there are wires to access, wires to cross the septals, wires to penetrate caps, wires to externalize, etc., etc. So we use the cyan wire as a workhorse wire to access the area of our retrograde. We took our microcatheter down there, and then we know, if you look at it, we have this, we know where the septal is, which one was our septal to go from the right to the left. And once we engage our microcatheter in this segment, then I need to change the wire, a wire that would cross the septals. So that, and everyone is different, and there's no single wire that, everyone is different. So we minimize the amount of wires that we have in our lab. I typically use 2 wires for the septals, either the SUO3 or cyan black or sometimes cyan, and for the epicardial it's about the same. So we access that with the cyan, and I took the SUO3. SUO3 is a 0.3 gram wire, very soft wire, and one beauty of this wire is a very, very safe wire, and if you can't cross with a SUO3 and it gets tired, you would not actually damage any of these septals. So I tried in this case with the SUO3, and SUO3 you don't torque it as much because it could loop around this and form a knot. So you just change directions and let the wire go with the flow. And surprisingly, even though they look fantastic collaterals, the SUO didn't go. So in my algorithm, if the SUO doesn't go, I change to cyan black. Now, cyan black is also a low-tip load wire, hydrophilic wire, and actually, I tend to spin a lot. I don't push too much on the cyan black. I tend to spin it a lot. And you can see the cyan black went easily retrogradely. And we take a retrograde injection, and you can see that the cyan black is in the distal cap. So next was, now we reached the distal cap, though we need to connect. As you recall, there was calcium in here, there was tortuosity in here, and typically in these situations, because of the calcium, so I didn't use low-tip Fielder XTR, which was my usual wire, so I decided to go with the Gladius, or sometimes I use the Pilot 200, and try to connect retrogradely. And as you can see, the wire of the Gladius ES that I use in this example is stalling, is not progressing. I'm trying and trying, and I don't spend too much time trying. If it doesn't go, I escalate my retrograde wire strength. So we just had the Gaia Nix1 available, so I thought, okay, let's try the Gaia Nix1. One technical trick about the Gaia Nix series of these wires, if you counterclockwise it would become straight as like a knife, and when you go clockwise, it actually becomes softer. So even with the Gaia Nix1, we could not actually cross retrogradely. And by the way, the tip load of the Gaia Nix1 was less than the Gladius. So this was expected, but I only had 1 wire of this and 1 wire of the Gaia Nix2. So I decided, okay, let's escalate further. So this is where we are in location. And you can see, as we discussed earlier, that now we can see the tortuosity. We probably in the vessel architecture, but not inside the lumen. But we need now to connect from here to here. So we went back to escalate it retrogradely with, just to make a puncture retrogradely with CP12. And now you can see CP12 made some progress retrogradely, but definitely, sorry, that's the case. This is CP12. I'm just going to go fast further. So we're moving with a CP12, biplane, LAO, RAO, and you can see the CP12 is progressing, but definitely it's not in the vessel wall. it's not in the vessel lumen. It's somewhere there, but I don't know where the wire is. As long as we shouldn't worry about the wires where it's going, but I would worry if I follow that with a gear. So don't follow it with a gear, but I use that as a...
It's okay. Just 1 second. For those who wants to go for prayer, now bus is leaving, but otherwise you can stay. Can you continue, please, the movie?
So the wire is playing somewhere, but definitely it's not in the lumen. So now we need to solve this issue with an algorithm. So we kept that wire, retrograde wire, and we said, okay, let's puncture. Now we know roughly the cap is in here, in that area. Let's try to puncture that, the proximal cap, and try to get this area connected. So I use the Gaia next. It gave me some purchase, but not enough. Again, calcium, right? So then decided, okay, let's escalate the wire again, and we escalated it with the next wire for me is CP12, Confianza Pro 12. So now you can see I'm at purchase. These two wires are close in terms of proximity. You look at it in different angiographic view, make sure that these wires are dancing with each other. Now I'm pretty much confident I'm in the vessel architecture. I don't care whether I'm in the lumen, I'm in the wall, as long as I am in close proximity. So then we actually purchased, and I used the Gladius Mongo with the purchase of knuckling it, because I know there was a tortuosity, and look what happens to the knuckle of the Gladius. I could push it, and then it becomes very small knuckle and jumps into a branch, AKA contemporary star. It's a name I just created myself. It's not true, okay? So the knuckle goes into the diagonal, and now I'm confused. Am I true lumen, subintimal space, true lumen? Am I true lumen throughout? What about my retrograde? Where am I in the retrograde? Am I in the true lumen backwards? Am I subintimal? I'm confused. So to solve that issue, I only need 7, maybe 5 more minutes.
Those who are staying, خلاص. Continue, Doctor. We are having lunch here anyway.
No, thank you. So the knuckle, so now that's the confusion and we need to solve it. So I advanced my microcatheter in that diagonal. I injected retrograde. I know I'm in the diagonal. I switched back to the cyan. I don't want to use a stiff wire there. And then the solution to that is to put intravascular ultrasound. So we put an intravascular ultrasound from here all the way back. So I want to know what's happening in the proximal LAD in the CTO segment. So when I vested here, in this segment, if you look at it, it's in the true lumen. So I know it, it's good. Pull back the IVUS, and you can see I'm in the false lumen. So this segment is false lumen. Still false lumen. So I have a short area in the subintimal space. And then, as we discussed earlier, in the proximal segment is a 360 degree of calcium. So we're probably going subintimal space, true lumen, subintimal space, true lumen. So, and we need to connect all these together. So then I said, okay, so I knuckled antigrade. I pulled the Gladius out from the diagonal. I tried to push it further to the proximal LAD. And then I advanced on the diagonal wire. I advanced a guide extension to do a reverse cart. So we did that with the Gladius, and the wire goes into the guide extension. And you advance your retrograde microcatheter, exchange your Gladius to RG3, which is your externalization wire. That's a reverse cart, what we did. Balloon proximal LAD, gladius went in there, and you went back into the left main and the guide extension. So that's the RG3. RG3 is a wire dedicated for externalization. It's 330 centimeters, very tip load of 3, but the body is very soft. And then we exchange the procedure from retrograde to antegrade, and we did PCI as usual. We use, in almost all of our CTOs, we use imaging. Specifically, we use the IVUS, balloon, stent, and this is the final. I'm going to stop 1 second in here. If you look at this area, we actually IVUS it, and unfortunately I don't have it in here. It's all negatively remodeled. So you need to hold your temptation of stenting it. And when I see cases like this, or our practice is when we see something like this, I actually bring them back in about 2 months' time for a check angio and reassess the situation, because most of these would grow over time. And that was shown very clearly in the consistent CTO. We saved the branches, stented it, avoided complications, just using the tools of wires that you have and planning the procedure appropriately.
Excellent.
So this is the wires from the that we have used. I think in this case we've used 11 wires. I'd like to thank my center and the administration to allowing us to have the ecosystem to do such procedures. I'd like to thank my colleagues, Dr. Sadaranda and Dr. Noor, for the great support and help that we work together. And last but not least, I'd like to thank you all for attending this and appreciate your attention. Thank you very much.